For everyone's reference, today's agenda can be found under the first tab in the meeting's materials. As a reminder for everyone, please remember to use the Healthcare Cost Transparency email inbox to send updates or questions. And I will now turn it over to Chair Dr. Judy Zerzabol to call the meeting to order.
Excellent. Hello, everyone, and welcome, committee members. It is now 2:02, and I call the August 20th meeting of the Advisory Committee on Primary Care to order. Thank you all for joining us today and your continued work throughout the year. I'm very excited about today because not only is this our final Primary Care Advisory Committee of 2026, but it's also sort of the culmination of a year's worth of discussion, research, presentations, deliberation. As a reminder, today's meeting may conclude as late as 4:30 p.m. to allow time for discussion and vote. We'll sort of see how it goes, but I wanted to make sure we had enough time to talk. And throughout this year, the committee has explored one central question. How can Washington strengthen primary care as the foundation of a healthier, more affordable, and sustainable healthcare system? A question dear and near to my heart, and I'm hoping we make some progress. So our charge is to help the Cost Board better understand the role of primary care in creating a more affordable healthcare system and to develop recommendations that we will vote on today that can inform future action for the Cost Board as they start piecing together their annual report that goes to the legislature. Those primary care policy recommendations help shape how Washington thinks about investing in primary care, not just because it's another area of spending, but because it is foundational to the health outcomes the Cost Board is working towards. We know that when primary care is adequately supported, patients receive more preventative care in a timely manner, chronic disease is better managed, unnecessary visits and hospitalizations can be reduced, all of the good things we want. Also, I think many of you have probably seen the recent Milbank report that notes investment in primary care increases affordability. And so I just want to say strengthening primary care isn't separate from the affordability issue. It's one of the most important strategies we have. So today's agenda reflects that progression. And the agenda is here on the screen. So we're going to start with the approval of our June meeting summary. We're going to hear public comments. Then we're going to review an update from Ingrid Ulrey, who is with the Office of the Insurance Commissioner, and we'll talk about the Universal Primary Care Proposal. We'll review a summary of the July Cost Board meeting, examine our new and improved primary care spending data, and then finally we'll spend the rest of our meeting discussing and voting on this committee's primary care recommendations to the Cost Board. So I'm going to begin roll call. I'm going to call on members by first name in the order listed on the agenda, which is in alphabetical order by the last name. With the exception of the chair, Jonathan, I'm calling on you first. When I call on you, please unmute your microphone and let us know that you're here. And then please stay on mute except when you want to talk. So Jonathan?
Hi, I am here. Happy to be here.
Excellent. Hello, Crystal?
Yep. Good afternoon.
Hello, Sharon?
Could it be Shannon? People often call me Sharon. Shannon Fitzgerald?
Nope. Shannon is later, but yes,
Okay.
Thanks. I can mark you off now.
Okay.
Tony, I know, is not going to be here. Michelle?
Good afternoon. I'm here.
Great. There's Shannon, who's already here. Chandra?
Oh, hi, I'm here.
Excellent. Elizabeth? I think she's going to join us a little late. Oh, are you here already?
Actually. Yes, I'm here.
Excellent. Welcome. Lon?
Thank you.
Hello, I'm here.
Hello. I almost said good morning. Good afternoon. That's better. Katina?
Hi. I'm here.
Hello, Mandy. Ginny.
Good afternoon.
Hello. Sean and Stacy are not going to be here. Maddie.
I am here. Good afternoon.
Great. Meg. And then we have a couple of repeats, so I think that's all. Is there anyone on the committee that I did not call?
Okay, Judy, I counted 11, so we have enough for quorum.
Perfect. Thank you. So please join me in turning to the June 25th meeting summary and the meeting materials. As a reminder, the recording of our last meeting is posted on the web page. Is there any discussion of the meeting summary or proposed changes? Then would someone like to make a motion to accept the summary?
Motion to accept this summary. Second.
Excellent, thank you. All in favor say aye.
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 Okay.
Aye.
Any opposed? And the June 25th meeting summary is approved. I'm gonna turn it over to Rochelle for public comment.
Thank you, Judy. If a member of the public wishes to provide public comment, please raise your hand. When you are called upon, please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. To provide verbal public comment, one of our staff members will enable your microphone and camera, which may take a moment to connect. To keep to the meeting agenda, verbal public comments are limited to 2 minutes. The committee will listen to all public comments received during this time, but may not respond to comments. So let me go ahead and check to see if we have any hands raised. I am not seeing any hands, but our public comment time is slotted for 2:10, so we're gonna have to give it a moment. So I will make an announcement to fill the time. Just to let you all know that we have made a few modifications to the meeting packet that you are all seeing today on the screen. This is slightly different than the packet that went out last week. I believe it's tab 4, the OIC updates. We do have slides in here now rather than just a report. So we will be updating this to the website post-meeting. And just for your reference, that's the one difference. Okay, so it's 2:10 now. I am not seeing any hands, so we can go ahead and close public comment, and I'm gonna turn it back over to you now, Judy.
Excellent. And I didn't look, but I think is our next agenda item is an update on the universal primary care proposal from OIC. I think is Ingrid on?
Let me check. She did send an email saying she was traveling, so it may be Nico in her place. Let me check to see if either of them are on.
Doesn't look like Nico's here yet either.
Yeah, I'm not seeing either of them.
I'm
So
here.
if we want,
Oh, excellent.
oh,
I'm here.
Nico is here.
Yeah,
Okay,
just-
I'm sorry about that, Nico.
no worries.
We must have missed you. Okay.
Okay,
problem.
so Ingrid might join us, but she is traveling. She's the new Senior Health Policy Advisor at the Office of the Insurance Commissioner, and she is a cost board member. Nico are you a policy analyst? I don't know what your title is.
Yes.
Excellent. He has been at the HIP and has been working on this with Jane before she retired, and Ingrid has taken that position. So over the course of this year, our committees discussed a number of approaches for strengthening Washington's primary care infrastructure And today's presentation builds on many of those by exploring one long-term vision for improving access to comprehensive primary care while reducing administrative burden. So Nico, thanks for being here, and I will turn it over to you.
Thanks so much, Judy. About how much time do we have for this portion? I want to make sure I'm not, I'm staying within your allotted time for the meeting with everything.
Yes.
We have this slotted for 15 minutes. But if it goes over, that's okay. We do have 30 extra minutes built into this meeting agenda today.
Okay, sounds great. Thank you so much, Judy, for the introduction. It's nice to see everybody on this call. I know a lot of people. So I work in OIC's Policy and Legislative Affairs Division. And I think that Jane Beyer, before she retired, spoke to this group a little bit a few months ago. But Insurance Commissioner Kuderer, is one of the things she consistently hears from insurance consumers is their difficulty in accessing primary care, getting into primary care appointments, and sort of having a strong foundation in primary care in our current system. So we're going to talk a little bit about OIC's proposal for primary care. You can go to the next slide if it's Audrey or whoever is managing the slides. Thank you. So I think, most people in this group, this is not, these are not new ideas or findings that Washingtonians are struggling to access primary care. But we have some data points here in terms of a large number of Washingtonians lacking a usual source of primary care. This comes up in our complaints for our consumer advocacy program. Everyone in this call also knows that the state and across the country are grappling with primary care provider shortages and burnout, as well as administrative burdens in the practice of primary care and lower reimbursement relative to subspecialties and other specialties in medicine. And also, as this group knows, the legislature enacted a law several years ago with a goal of spending 12% of total medical expenditures on primary care. My understanding from the healthcare authorities, data collection, as well as the collection we're starting to do, is that we've been significantly under that amount. You can go to the next slide. So Commissioner Kuderer and OIC are likely pursuing agency request legislation to be considered in the 2027 legislative session that would establish goals for a new primary care financing and payment system, specifically to direct our office to work with the healthcare authority, other agency partners, and stakeholders, including providers, carriers, consumer advocates, unions, to report back to the legislature with a design of a primary care financing and payment system, specifically address a number of really good, really complicated questions people have been asking us about this plan, about this idea, from the delivery of care to reimbursement to the scope of services included, to how it would work with existing health coverage that people get and wrap around their coverage, the provider workforce issues and all of that. OIC's proposal would use the commissioner's regulatory account that's funded from insurers' premium taxes and not compete with the legislature's decisions over general fund resources. You can go to the next slide. I mentioned a few of these pieces over the last slide, but to give you more of a flavor of the concept that this legislation would direct us to look at and work on, is that primary care could be carved out of the traditional insurance-based benefit design, with traditional insurance wrapping around to provide all of the other coverages and benefits that are outside of primary care. We feel this type of model has promise to improve consumer access to primary care, as well as in a more integrated way. And so, we are wanting to look at alternative models like advanced primary care, integrated behavioral health and primary care programs, and direct primary care as Models we know are out there in various stages and in various provider groups to inform this work. We're also considering the way that reimbursement could potentially better support primary care providers and practices with more stable revenue, for example, through a per member per month payment as opposed to the predominant fee-for-service reimbursement that we know is more the norm today. And looking at a uniform financing structure that could account for what we're currently spending on primary care and hopefully pursue achieving long-term savings from administrative simplification, as well as really trying to have a stronger primary care foundation help reduce avoidable emergency hospital services, all of the various services we feel primary care is really important to help mitigate and help better manage chronic conditions. You can go to the next slide. We know that a lot of primary care providers and facilities providing primary care are dealing with significant administrative burden, prior authorizations, coding and billing systems, and part of this proposal we are making is to look at how that could be simplified or reduced, because we know that the practice environments can be really tough. And we want to empower primary care providers to practice to their full scope and spend more time with patients. You can go ahead to the next slide. I mentioned before that this potential legislation would include thinking about a better, more predictable, stable reimbursement method. We would also be considering how to assign or attribute patients to practices, which I know is a big focus always when we're talking about alternative payment models and ACOs, for example. We also know that while the state, including with OIC and HCA, can directly regulate certain types of health plans, we're also preempted from regulating some of the market, namely Medicare and self-funded group health plans. So we'd be considering what it would look like to do a phased-in approach for this. You can go ahead to the next slide. These are some of the design elements that we would be looking at. I think I mentioned almost all of these, but the phased implementation, what federal waivers may be necessary in the future, rural healthcare delivery and access challenges, reimbursement, financing, and governance. You can go to the next slide. Okay, we have some references there. This is literature that a lot of people are familiar with. So we are actively talking to various stakeholders and people who have a part in this current system and care about primary care. And we are very open to input as we pursue this. This is really important for our insurance commissioner. And we are really grateful for the time to talk to this group about it. And to the extent possible, utilize and be consistent with all of the great work this advisory committee has done to look at the scope of primary care, to look at common quality measures, and a number of other areas. So I think there are a few questions, and I'm happy to spend whatever time we have to try to answer those. Thank you very much.
Yes, and Ingrid's here, so so both of you can chat.
Hi, Dr. Zerzan. Apologies for being late. Thank you, Nico, for covering this. And hi, everyone. I'm Ingrid Ulrich, Senior Health Officer with the OIC, and to the Commissioner. And Nico, thanks for covering that. We really do welcome your feedback, questions. We know this is a lot of familiar territory with all of you as you're experts in this field, and really honor and respect that. And thank you for your leadership in establishing the spending goal for our state. And our hope and aspiration is the policy such as this could really set the stage to have the structure that would enable us to do that hard work, to reduce the rate of growth with the large drivers of healthcare costs, including hospitals and pharmaceuticals, while allowing more growth and more investment in primary care. And Judy, oh, sorry, Dr. Zuzan, can I ask you, can you hear me okay?
You're a little choppy, and your video freezes a little, but I think it's okay because we don't need you for a lot longer.
Great. I'm so glad Nico's here. Thank you.
Yes. Yeah, it is better when you turn off the video. Do folks have questions?
Oh, okay. I'm going to do that then. Thank you.
Do folks have questions for Ingrid or Nico? Ginny.
Hey, Ingrid and Nico, I'm curious, is this being talked about in any other states? And what, if that has happened, are those conversations like?
Yes, it is. There are various proposals that I think have a lot of similarities with what Commissioner Cooter and OIC are pursuing. Massachusetts recently, or their legislatures considering a bill that would set a threshold for primary care payments similar to what we already have, but it would have more kind of accountability mechanisms, potential performance improvement plans to achieve that, as well as the development of a similar model as what we're considering here. There's also, I believe, a proposal that is working its way through the relevant groups and provider groups in Vermont. And then I think there may be one or two other states. However, just to be honest, there is not a state that has implemented an alternative financing model as we are pursuing and would be pursuing, supported by this legislation, to come back to the legislature with. But there are a handful of states that are also interested and I think recognize a lot of the same issues and problems they're seeing.
I'll add Oregon because I recently talked to them is thinking about this, and I think California is too. So there's a lot of interest in this idea. But yes, no one's quite done it yet, but there's a lot of really smart people thinking and talking about it. So it's fun to be in that mix, I think.
I'm sure there will be a lot more questions, and we're very open to talking to folks, you know, over the next few months and as we get into the legislative session. Oh, okay, looks like we have another one. Hi, Shannon.
Hello, I think this is a really exciting proposal and it seems really well thought out. I remember when the article that is in your bibliography came out in the Seattle Times about the shortage of family doctors in Washington State, that I'm with ARNPs United and also work with a coalition that includes the PAs. And we had written an article back about that, describing how much care, for instance, with Medicaid and rural populations is being delivered in primary care settings by nurse practitioners and PAs. So I feel compelled just to raise my hand and say, I hope that when you're thinking of providers, you include the wide range of us that are out there in the primary care settings.
Yeah, thank you, Shannon. I think we absolutely are. I mean, NPs are super critical as primary care providers across the state. And yes, that will absolutely be a component and part of the provider community that we'll want to keep working with to get your input.
Great. From billing data, what the proportions really are. Anyway, so thank you so much for thinking it through. Appreciate. We'll stay tuned.
Thanks, Shannon. I don't know if I caught the very beginning, but I caught the very end, and hopefully there wasn't another question in there, but thank you.
No other questions.
Dr. Zuzan, can you, it's Ingrid, can you hear me better now with camera off?
Yes. Yeah.
Okay, thank you. I just wanted to say again, thanks to this group, and note that this has been an iterative process that Nico and I and the commissioner herself have had dozens of conversations over the last several months. I know that my predecessor, Jane Beyer, came to speak to this group back in April. And since then, there's been more research that we've been doing internally. We did do a poll of our consumer complaints and seeing a real trend and pattern there that really affirms the sort of more anecdotal experience that the commissioner has had around the state wherever she goes of people raising the concern that coverage doesn't equal access. And there a lot of frustration that people can't find a primary care practice that can accept them accept them as a new patient, or they're waiting many months to get their first appointment. So she's feeling a lot of frustration in community, getting that also from other legislators. So we have had to inform this proposal. I would say it has also been quite inspired by the recent JAMA article by Ziri Song and Dr. Kevin Grumbach and others, really in a thoughtful way spelling out the multi-payer common fund model that caught our attention and feels very aligned with the approach here that builds on reforms that have already occurred in our state and many others of innovating towards more of a prospective payment and common measures and spending goals, or things that so many of the states have done, but to really accelerate and make us be able to be successful in those policies. Creating a carve out from traditional insurance is a structure that we feel that could accelerate and enable us to meet some of the goals that you all have been real leaders in over the past many years. So I hope that that this can be something that you take to the full commission, to the Healthcare Cost Transparency Board, which I sit on that board for discussion. So I really appreciate the time today, and just any final questions for myself and Nico. We want to respect your time and getting on with your agenda.
Excellent. Thank you. Yes, I look forward to potentially adding this to some of our recommendations that we vote on later in the meeting. And thanks so much, Ingrid and Nico.
Thank you. And sorry, one last thing, Dr. Zerzan, I'm not sure if Nico covered before I got on, but we have been also talking actively to legislators about this request legislation. And we do have a sponsor in the House, Representative Lisa Parsley from the 22nd Legislative District. And we have several senators, people on the Senate side, interested in being the sponsor, and we'll be figuring that out by the end of the month or so. So this does have traction to appear as a legislative vehicle in the 2027 session. Just want to make sure that was clear.
Excellent. Thanks.
Okay, thank you.
Thanks.
And I'll
So,
be signing off. Oh,
okay, thank you.
thank you.
So next, I'd like to spend a few minutes bringing everyone up to date on the July meeting of the Cost Board. You will note in your packet there were a lot of slides. I'm going to move through them very quickly because, one, I want to keep us on track, and there's a lot. But I wanted to make sure they were included in today's meeting packet so that you have the background context, because some of the discussions at the Cost Board's July meeting are relevant to the work of this committee, and I think might help you with the recommendations. So I hope that you had time to look at them, and if not, I'll flip through them quickly. So next slide, please. So there were three focus areas. One, a really interesting conversation about Colorado. And then the second area, California's market oversight program. And then the third area was the Cost Board's discussion and vote on market oversight. So next. So the primary care payment overview from Colorado was done by Tara, Matt, and Rachel. Next. Next. So the first part of their work is this primary care payment reform collaborative. Oh, next slide is good. Yes, which connects with the legislature to make to be a state-based multi-stakeholder forum. And then also affordability standards are new regulatory tools that their Office of the Insurance Commissioner has. Next slide. So this is that multi-stakeholder group. I'll note it's similar to what we have, except ours are each of them separate tables. So there's employers, actuaries, clinicians, consumers, insurance companies, the Medicaid agency, CMS, and their public health agency. Next. They, like us, are looking at primary care spending. You will note that their overall percent of primary care spending is 16% in 2024. And they have a very high rate of primary care spending for their Medicare Advantage plans. Next. Some of their lessons are that legislative champions are important, but you need a pipeline and think about several different levers. When measuring primary care spending, don't let the perfect be the enemy of the good. Learn from peers and strike a balance between carrots and sticks to get there. Colorado has this ACC model. They have one managed care plan, but mostly they have this managed fee for service that is done by these regional entities. Next slide. They have a practice assessment, which is similar to our recognition program here in Washington with 3 tiers. Next. They have an integrated behavioral health part of that practice assessment that allows you to be eligible for an integrated care PMPM. Next slide. And these are the 10 domains on their practice assessment, which I think are very similar to our recognition project or program. Next slide. Then this was the Office of Healthcare Affordability from California. So their presentation next. This office was created by their governor in 2022 to do similar things to what the cost board is doing. Think about slowing spending growth, but specifically they review consolidation of health systems and promote high value. Next. This is the merger trend in California, which, as you see, is going up in the health system and in the corporate ownership or private equity spaces, and that independent practice has gone down about 12% over these 4 years. Next slide. And in the first 2 years of their review of market consolidation, in the first year, they had 12 pre-filings with 14 transactions, and in 2025 to 26, they had 14 pre-filing meetings and a total of 35 transactions. So they were busy. Next slide. Some of their lessons learned are that healthcare entities are not always a party in a transaction, that ownership can be opaque at times, and that the timelines for review can be challenging based on what the companies want to do, and that it's important to get sufficient information and have documents to facilitate that impact analysis, and that pausing to make sure critical information is included is also essential. Next slide. Then on the market oversight, next slide. So this was a review of what the cost board has done over the course of the year. Next slide. And that their goal is really seeking balance, knowing that there are benefits with healthcare consolidation and also potential risks. Next slide. So our current gap is that Washington has limited authority to review and monitor healthcare market activity. Oversight laws are in place for insurers, but not for hospital and provider consolidation. And in contrast, California and Oregon both have more robust market oversight frameworks. Next slide. Some of the aspects of the healthcare system that are thought to need to be preserved in the face of consolidation, and this is from the Healthcare Stakeholder Advisory Committee panel, is primary care is number one, but also these other areas. Next slide. And then strategies to address healthcare consolidation are there's a NASHP model to address consolidation that looks at limiting the behavior of already consolidated systems, and then thinking about steps and levers to prevent further consolidation if it appears that that could have negative repercussions. Next slide. So this is a summary of the cost board and the advisory committee's discussions that our healthcare markets are moderately to highly consolidated, but there is opportunity here in terms of thinking about impacts around increased prices and consumer cost sharing, some mixed effects on access, quality, and experience, and then workforce aspects. And there are some contributing factors to that, but actions include that market oversight can support that Washington's goals are met around cost equity, access, and quality. It'll allow for an increased voice for consumers and stronger transaction review and oversight laws. Next slide. So how other states have approached the oversight is this is where we are. We have a pre-transaction notice, but California and Massachusetts have the notice plus transparency and reporting authority. And then Oregon and New Mexico have the authority to approve or disapprove transactions. Next slide. Oregon has one of the strongest market oversight programs. They presented to the cost board earlier. Next slide. And during reviews, that program looks at how a transaction could affect healthcare costs, access to care, quality, market consolidation, and health equity. Next slide. These are the outcomes: approved, approved with conditions, withdrawn, or disapproved. Next slide. California, their transaction review law requires a 90-day advance notice. And then the California Office of Healthcare Affordability has 60 days to make a decision. They do not have the authority to block or condition transactions directly, but they can have action by their state attorney general. Next slide. This is a review of other states in terms of Massachusetts that's similar to California, and New Mexico that is similar to Oregon. Next slide. So the cost board recommendation and vote. The board voted yes for recommending the legislature establish a stronger oversight program that captures the full range of healthcare entities. Next slide. Board members really had a lot of interest in understanding the broader picture of what's driving consolidation, how it's related to overall costs, and if there are alternatives to consolidation. They also expressed a variety of ideas about pursuing multiple strategies to limit price growth, noting that affordability is worsening. So next slide. And that is all. So now we are going to move to some conversation about the latest data. So throughout the year, we've talked about the importance of moving to achieve that 12% spending target. So our data team is going to review an updated picture of where we currently stand on primary care spending targets. I am super excited to share this data because for the first time, it includes non-claims-based spending. And so I'm going to welcome Sheriel, our Health Economics Research Manager here at HCA, to walk us through the latest primary care spending data. Over to you.
Thank you, Dr. Sursan. Yes, I'm also excited to present the findings of the recent data because in the past, we've always wondered what is Washington State's actual primary care spending if we account for non-claim spending on primary care. I remember we prepare some presentation on primary care and we always have kind of like this asterisk or caveat saying that this number is incomplete because we don't have non-claims data. So this year, the cost board actually started collecting this data, and now we have a more complete picture on primary care spending in the state. So super excited to present the findings. Before I do so, if I may, I want to give a quick shout out to the rest of the data team, Ross McCool and Kathy Temple, for all the excellent work done to collect, validate, and analyze the data. Also, a quick shout out to our data engineers who helped us along this process. All right, next slide, please. All right, the presentation is outlined as follows. First, we will provide an overview of the cost board's data call, focusing on the latest one, which is the source of the non-claims primary care data. And then we will proceed to the presentation of the findings. We will end with some notes on limitations, our conclusions, and a little time for Q&A. Next slide, please. All right. Key takeaways from this presentation. Number one, as of 2024, based on the data that we collected, primary care spending constitutes 6% of total medical expense. This is half of the 12% target set by legislature in RCW 70.390.080. And the bulk of this 6% comes from claims spending and 0.8 percentage point come from non-claims. If you look at like the proportion to TME, the commercial market has registered the highest spending on primary care as a percent share of TME at 6.7%. This is followed by Medicaid at 5.8% and Medicare at 5.0%. And then if you look at year-on-year changes, compare the 2023 ratio to the current ratio in 2024, the percent share of spending on PC actually didn't change and have remained flat in 2024. Next slide, please. All right. As mentioned earlier, the most recent primary care data that we use for this analysis comes from the cost board data call. This year's data call collects 2023 and 2024, and this adds to the historical data that we have collected in the past. Since we started collecting data in 2022, we collected claims spending on primary care. So we have claims data on primary care from 2017 to 2024. In last year's data call, we started getting primary care based on the new definition approved by this committee. So we have claims data on old definition from 2017 to 2022 and on the new definition from 2022 to 2024. This year, we started collecting non-claims data on primary care. So we have non-claims data for 2023 and 2024. Next slide, please. The 2026 data call was launched in February this year. So we received data submissions from data submitters in April, conducted data validation in the second quarter. Currently, we are in the analysis phase, and this phase includes doing this preliminary analysis on primary care. We consider this preliminary because while it is unlikely, we may still get resubmissions at this point because we are still getting feedback from providers. We will conclude the data call with a public hearing in November, and that includes a comparison of statewide provider and carrier performance or healthcare spending growth against the benchmark. Next slide, please. Thank you. The healthcare spending data we received from the data call could be aggregated to get the total healthcare expenditure, or THCE, for the state as a whole. The THCE could be broken down by TME, or total medical expense, NCPHI, or net cost of private health insurance, and other spending that basically comes from healthcare spending paid by the VA, the DOC, and LNI. Primary care data comes from the TME side, which is the sum of claims and non-claim spending paid by commercial payers, by Medicaid, and by Medicare. And TME could be stratified by markets, carrier, and large provider organizations. Would like to note that for Medicare FFS, we have excluded data from Medicare FFS in this analysis because the structure of the data does not break down primary care into claims and non-claims. Next slide, please. All right, now that we got an overview of where the data is coming from, I'm going to provide a quick overview of how a claim is classified as PC based on the new definition. So a claim is classified as primary care if it meets three conditions. First, the service should be one of the services listed in the first list or the first column of the slide. And then second, if the service is provided by the type of providers in the second column here. And what Shannon mentioned earlier, I would like to highlight that the primary care service is not only rendered by physicians, but also by other type of providers like nurse practitioners and clinical nurse specialists. The third condition for a claim to be considered primary care is that the service should be rendered in one of the locations in the third list in the slide. Next slide, please. So going to non-claims definition, non-claims spending on primary care are payments that may not appear on a claims form, and this includes capitation, salaries, incentives, population health payments, and practice support payments. Next slide, please. On to the exciting part. Next slide, please. All right. Let's take a look first at the breakdown of total primary care spending now that we collect non-claim spending on primary care. Looking at the graph, the first two, the first two bars in this graph represents like the overall primary care market breakdown, and we can see here that about 15% of total primary care spending is on non-claims, and about 85% is coming from claims. If you look at by market, the breakdown looks different. The markets are commercial, Medicare Advantage, again, excluding Medicare FFS because we don't have data on primary care non-claims, and then Medicaid. For commercial, almost all PC spending is claims-based. So we will see later that collecting non-claim spending did not really move the needle on the commercial markets percent spending on primary care. For Medicaid, almost 40% of total primary care spending is non-claims, and for Medicare Advantage, about 21%. Next slide, please. All right, this slide contains one of the highlights, if not the highlight of this presentation. The graph on the left shows primary care spending per member per year, and the one on the right is primary care spending as a proportion of total medical expense, or TME. The vertical line on both graphs that crosses year 2022 indicates the time when there was a shift from the old definition to the new definition. So data to the right of the line indicates that numbers are based on the new definition, and data to the left are based on the old definition. And the broken blue line indicates claim spending over time, and the solid line represents the total spending on primary care. The gap, therefore, between the solid line and the broken line represents the non-claim spending. So looking at the left-hand side graph, on average, about $491 or $500 is spent per person in primary care in 2024, and about $426 of this is claims-based, and about $65 is non-claims. And to provide perspective, total medical spending per person per year in Washington is about $8,000 in 2024. So this primary care spending is about 6% of TME. This 6% is 6 percentage points lower than the 12% target set by legislature. And we can see that the additional collection of non-claim spending notched the proportion by 0.8 percentage point. Looking at the year-on-year change from 2023 to 2024, there is a $47 increase or 10% increase in total PC spending. But as a proportion of TME, the right-hand side, you can see that there's no change from 2020 or significant change from 2023 to 2024. And the proportion has remained flat from this time period. One thing that probably stands out is that in this graph, you could see this big jump from 2022, 2023 in that broken line or the claim spending. And we will discuss this in greater detail when we focus on claim spending in the other slides. But this increase is due to data submitters' improved ability to identify primary care spending starting in 2022. So there's like a caution when we're interpreting this trend. Next slide, please. The addition of non-claim spending on primary care has different impacts by market. As we can see on the left graph, the difference between the broken line and the solid line for each color reflects the impact of the non-claim spending on primary care. So looking at the green line, which is Medicare Advantage, and the blue lines, which is Medicaid, we see a noticeable gap between the broken line and the corresponding solid line. For the green lines or the Medicare Advantage market, this gap is about $176. And for the blue lines or the Medicaid market, about $130. And then for the purple line representing the commercial market, there is no gap between the broken and the solid line, indicating that the non-claim spending is close to zero. That means that there's no change in total PC spend for the market if we add non-claims data. In terms of proportion to TME, as shown in the right-hand side graph, non-claim spending had no impact on commercial, with the share of spending remaining at 6.7% in 2024 with the addition of non-claim spending. It does have a more notable impact of about 2 percentage points and 1 percentage points on Medicaid and Medicare Advantage markets, respectively. And as of 2024, the percent share of primary care to TME is 5.8% for Medicaid and 5.0% for Medicare. Next slide, please. Now looking at the year-on-year changes from 2023 to 2024, focusing on those two years, we see that while total primary care expenditures per capita increased across markets from 2023 to 2024, you'll see like across colors, there is an upward trend from 2023 to 2024. If you look at the right-hand side, the proportion or the spending on PC as a percent share to TME decreased in the Medicaid and Medicare Advantage markets, which means that spending in other categories also increased. There's no change in the commercial markets, so like the proportion has remained flat for commercial. Next slide, please. All right, for non-claim spending, would like to start that non-claim spending overall without, distinguishing what kind of service categories, approximately 10% of TME. And only 10% of this 10%, or about $65 per year, is spent on primary care. Most of these non-claim spending spent on primary care are capitation or performance incentives. If you look at by market, non-claim spending overall is less than $10 in the commercial sector, and only $2 is spent per year on primary care. Medicare Advantage has more non-claim spending overall in dollar amounts, but a lower proportion of less than 5% is spent on PC, about $176. And for the Medicaid market, that $130 spent on PC is about 17% of total non-claims. Next slide, please. Looking at the claims spending now, you can see that we have a longer historical data on claims-based spending on primary care, but it is challenging to compare the trends over time because number one, we use various definitions, one before 2022 and a new definition after 2022. So we can interpret the data before 2022 because they're all apples to apples. Before 2022, we see a relatively flat claim spending on PC over time. Then looking at the new definition, we see a noticeable increase from 2022 to 2023, as explained earlier. Before I explain this, I want to note that in each data call, we recollect data for baseline year to ensure that we calculate the growth rate of the current year. When we calculate the growth rate of the current year, the data is internally consistent. So in last year's data call, we collected 2023 and 2022. And when we graph that, there's no noticeable increase year on year in claim spending from 2022 to 2023. This year, when we recollected 2023 data, with the new data, we see that there is a year-on-year increase from 2022 to 2023. So we asked data submitters what explains that increase, and they said that the increase is due to improvements in data reporting from carriers, specifically in the commercial and Medicare Advantage markets. Looking at 2023 and 2024, there is a $50 increase or a 13% increase in claims spending, but as a proportion of TME, it is flat at 5.2%. Again, indicating that spending on other categories are increasing as well. Next slide, please. Yes, thank you. Looking at claims spending by market, we see that there's a big increase from 2022 and 2023 in the Medicare Advantage and commercial markets. Again, this is due to improvements in ability to identify PC. Next slide, please. Okay, looking at thank you. Looking at the 2024 numbers, we see that per member per year, primary care claims spending is highest in the Medicare Advantage population across all years at $674 in 2024, followed by commercial and Medicaid. Looking at the graph at the right-hand side, we see that as a proportion of TME, claims spending on primary care is highest in the commercial market at 6.7% in 2024. Medicare Advantage and Medicaid are lower at 3.9% and 3.7% respectively. Next slide, please. Now moving from claims to total PC expenditures, but now we're going to take a look at the proportion of primary care spending to TME across carriers. So this box plot shows how the proportion of PC spending is spread out across carriers. In this graph, each carrier in each market is represented by this gray dot. In the commercial market, the proportion of PC spending is more spread out, while in the Medicare Advantage show a bit more clustering around lower values. Within each market, though, it's interesting to note that there is a single carrier that would have a primary care spending about 10% of TME. So in the commercial and Medicare Advantage markets, the carrier that reached more than 10% is Kaiserwa, and in the Medicaid market, this is Anthem. Next slide, please. Thank you. The next box plot shows the proportion of capitation spent on primary care. And we can see that the percentage of capitation expenditure spent on PC is highly variable across carriers in the commercial and Medicare Advantage markets. There is more clustering at the lower side for Medicare, which may indicate that Medicaid has more non-PC capitation arrangements. Next slide, please. This is the last box plot, which shows the proportion of performance incentive expenditures on primary care. And we see that is also very variable across carriers and markets. But in all these three markets, some carriers use performance incentive payments exclusively or almost exclusively for primary care. Next slide, please. All right, about to wrap up this presentation with a few notes on limitations and our conclusion. So on limitations, we'd like to point out that there's not enough data points to establish a clear trend yet of total primary care expenditure using the current definition, particularly for non-claim spending. But as we collect this data over time, hopefully we'll be able to have a clearer insight on the trends of primary care expenditure. Moreover, data improvements from carriers may affect interpretation of trends as we've seen from 2022 to 2023. And then also like to point out that Medicare FFS data is excluded because CMS reports different professional service categories. So in conclusion, next slide. Thank you. In conclusion, we see based on the new data that non-claim spending on primary care varies across market, but overall it is about 1% of total medical spending. And as of 2024, spending on primary care in Washington is 6% of TME, which is 6 percentage points lower or half the 12% target set by legislature. And I'm going to end this and see if we have questions.
Thanks, Sheriel. Nico?
Hi, Cheryl. Thank you so much for your and your team's hard work on the analysis. And it was really helpful to understand this. And the OIC has been working with HCA since the legislature passed a law, which we presented to this group on, I think, Senate Bill 5084. And so I just want to let you and the group know as well that we were just now starting to get the 2025 numbers per the OIC reporting template, which will be public information. And so we're just now collecting those, and hopefully that will help towards this effort about better understanding what's going out there in the market. So my understanding is those templates are covering the OIC regulated health plans, that is the fully insured health plans, and also PABCEB and Medicaid. So just an update for everybody that we'll be working on, making sure we collect that and can also support the legislature's goal of having that information be transparent and public as well. Thanks.
Thanks, Nico. Yeah. I think the 2 days could be supplementary because we don't have the breakdown by PABCEB and other populations. So I think they could really inform each other's results.
Yep.
Committee members, any questions, comments? Are you surprised? Not surprised? Shannon.
Well, just another comment on how great and comprehensive this is. And I'm not surprised, but I guess I don't know, it's just massive. So it seems extremely complete, and I think the job is fantastic.
Thanks. Yeah, they really sliced and diced the data a lot of ways. I feel like that was helpful. Elizabeth?
I am curious about the Anthem and Kaiser Washington spending more than 10%. And I don't know that I really have a question, but that just stood out to me. So thank you again for the completeness of this data set, because I think that will be very informative for other reasons.
We're definitely also wondering, what factors contribute to certain carriers meeting like, or having like a high percentage to TME. So that's really points us in the right direction, maybe to like take a look at like best practices by certain carriers or maybe even providers like that have proportion to TME that is close to target, and that could be informative on like policy recommendations or certain practices that we could adopt to encourage the primary care spending to increase.
Anyone else? Excellent. Well, thank you, Sheriel. It's very exciting to have the non-claims-based spend. It is disappointing that our primary care spend is still pretty low, but you know, that just means there is work for us to do on that. So next we're gonna shift to tab 7. About making recommendations. We've spent our time this year sort of looking at primary care spend from multiple perspectives. We've heard the data, heard from experts regarding some different payment models, feedback from the cost board and other advisory committees on market consolidation and primary care impacts. We've heard about workforce challenges and have heard about what other states are doing. So today's discussion is our opportunity to bring this all together. And before we dive into the discussion, I want to walk through some of the background and policy framing and sort of summarize where we are and the collective work of this committee. So next slide. So in 2022, in the Wayback Machine, the legislature passed a bill directing the cost board to define and measure primary care spending and to develop recommendations on how to increase primary care spending to 12% of the total healthcare expenditures. Next slide. And 12% is important because primary care is a fundamental part of the healthcare system, and primary care provides patients with an entry point into the healthcare system. It helps with prevention and chronic disease management. And research continues to show primary care and more primary care is associated with improved health outcomes, increased equity, higher life expectancy, and preventative services. And there is strong evidence, as I mentioned, the Milbank report, that supports the value of investing in primary care to get there, and that you get better health outcomes and lower total healthcare costs. All good reasons to support this work. So the framework for our recommendations, next. When we started this work a while ago, there are really 4 areas that can influence primary care spending. The first, I'm going to sort of go around in a clockwise fashion and start with direct investment. So pay more for primary care services. The second is capacity growth, so reduce barriers, have workforce investment so that there are more primary care providers, both doctors and nurses and PAs. Third is patient behavior, so help people understand the importance of primary care and help them find and access primary care services. And then the fourth one is reduced utilization of other services, perhaps and hopefully because there is improved primary care access. But if the total spending goes down while primary care spending stays constant, then there's a higher primary care spend. Next slide. So we are to make recommendations to the cost board that then those recommendations will go to the legislature. And so these are the principles we should follow, that whatever we recommend should be linked to that 12% primary care spend target. It should have ideally clearly defined action and people by which that action is done, be financially, operationally, and politically feasible, and improve access and quality, not just focusing on the money. Next slide. So the last 2 years, this committee has made these recommendations. Has made 2 policy recommendations requiring legislative action to increase primary care expenditures by 1% per year and to increase Medicaid reimbursement. And then the committee has endorsed these 5 other strategies that all had work underway or could be implemented without legislative action. Next slide. So this year, because perhaps sadly, not a lot of practice or progress has been made on these recommendations in the last couple of years, we decided to take a slightly different tack and really focus on 2 areas, diving into the details and hopefully with the idea of really moving these 2 areas. So the 2 that we focused on were increasing primary care expenditures and workforce development. Increasing Medicaid reimbursement, we did not focus on because of the state budget situation and that it was unlikely that will happen in the near term. And so hoping that these 2, we can really make a difference and suggest some changes. Next slide. So we have reviewed these 3 areas: increasing primary care expenditures, workforce development, and the healthcare transaction oversight. Next. And this is our process. We are going to discuss and vote on some discrete policy modifications, figure out final language, and vote on a final package to go to the cost board. Next slide. And here are, they're in your packet, some potential starting places. Next slide. So put into those 3 areas that we've looked at, increasing the primary care spending ratio. Primary care PMPMs have increased more slowly than other service categories. And again, in the data we just saw, that PMPM growth drivers differ by market and can vary widely across the state. For healthcare transaction oversight, about half of PCPs are now hospital affiliated and independent practice is declining. And the same office visit costs more when delivered in a hospital setting or hospital-owned setting. And integration shifts into hospitals can cost consumers more. And so needing to think about how that fits together. And then workforce development, we talked about some current initiatives in rural and tribal primary care, about growing your own, some K-12 and higher education investments, and our rural transformation work. Some future opportunities, I think, are the primary care recognition program, applying a workforce lens to primary care payer contracting and sort of thinking about that, and then encouraging everyone to practice at the top of their license. Next slide. So here's some proposed primary care recommendations. Next slide. So these are the recommendations I'd like to propose. They are for sure open for change and modification, and then vote. And so this is the slide we'll stay on for the remainder of the meeting. How I'd like to structure this is talk about each one of these areas and decide what our recommendations are, and then vote on each one, because I think then we'll have some deeper discussion about each of them. So for the first one, increasing the primary care spending ratio, although we've done this for the last couple of years, and actually the last couple of years, we wanted it to be increased by 2%, and the cost board last year decreased that to 1%. But I think we should, again, call for the legislature to use their power to require a 1% spending increase in primary care annually until we get to our 12% goal. Other states have done this, and it has required legislative action, I think, to move along those lines. And I think my personal view, we have tried to see if there is voluntary movement, and it's just hard. And so that is the first recommendation. Do people have questions, comments, want to recommend something else? Jonathan.
I like this one. I think it is evergreen. It's also in a green box. I am in favor of it. One thing that comes to mind, perhaps this is rosy colored, but maybe adding language to sustain so that it doesn't just reach 12% and then float right back down, because getting to 12% to maintain there would also include annual increases in PMPM spending to keep up with healthcare inflation.
Yes, I like that amendment. I don't know, can folks in the room, can you adjust that on the fly, or have a different place so we make sure that we capture this?
I'm taking notes. I don't think we can adjust this slide on the fly.
Okay, that sounds great. And yes, I do agree. I think one of the reasons why primary care spending the ratio has been relatively stagnant is because the rest of healthcare costs have been going up. Chandra?
Yeah, I'll just say that if we do recommend this, is there a general understanding that it would increase total healthcare costs? And is that a trade-off that we think is worth it?
That's a good question. I don't think it necessarily needs to. In that pie divided by quarters, if other healthcare costs are held constant, it can go up. So I don't think it necessarily needs to be new investment. Jonathan?
I forget if this analysis has been presented to this group before, but Kevin Grumbach, who's one of the authors of the Common Fund paper with Ziri Song that inspired the presentation given by OIC today, led another analysis that discusses like how what would happen to other categories of spending if we increase primary care spending by certain rates and if total healthcare expenditures are held constant. And in multiple different experiments, what was observed is growing primary care spend doesn't necessarily lead to higher total spending, and it doesn't necessarily lead to lower spending of other categories of care. It seems to result in slower growth in spending in those other categories of care. And so I do think that there's probably hard conversations to be had about what it means to grow primary care spend while keeping total healthcare expenditures growing at a certain rate. But I think in most situations, it doesn't necessarily mean cuts to other categories of spending or grossly higher spending, but it does mean that other categories of care would grow at much slower rates.
Yes, that's a great point. One other piece that is different about this, I think, than past is that it's not just carriers, but it also calls out that large provider organizations also increase their primary care spending. There has been conversation over the last few years that carriers or payers can spend more on primary care, but that may not trickle down. And so I will note this calls on both parts of the healthcare market to make changes. Let me see. I don't know who went first, Jonathan.
The one thing that I'm also noticing about this, and I'm not necessarily advocating for it, but I feel like if we are to have a conversation, it might be part of this recommendation. If these three are all is the totality of the recommendations, is this recommendation might be the vehicle for us to come out in support, in explicit support of common primary care common fund efforts, to the tune of carriers and large provider organizations, via a primary care common fund, increase primary care spending by 1% annually to reach 12% goal, versus us sort of tacitly endorsing efforts like we've done explicit recommendations in the past and more sort of subtle endorsements. I'm not sure if I have a strong feeling one way or the other, but I figure this recommendation might be the place for us to decide to do that or not to do that.
Chandra?
Yeah, I feel like this recommendation as written maybe is, I think I'd want to recommend that there's more analysis on how a recommendation like this would impact total costs and the various flavors of that, because there's different ways that you could do this that I think might have unintended consequences. And then there's ways that may actually achieve these goals and solve some of the cost issues.
Is there anything you'd like to change about it, or just note that that we need to think about those consequences or how to do this without increasing overall healthcare expenditures?
Yeah, I'd recommend maybe having some options for what this looks like and getting a financial analysis for those options.
Okay. Do you have ideas about options? I'm going to keep pushing.
Yeah, I mean,
Or
well,
anyone else?
one of them is the or I forget now who was talking earlier about the idea of kind of funding primary care and carving it out of insurance. So that could be one way where you're directly funding trying to get to 12% of spend. You could have carriers and providers invest. I think someone was saying that was an option. So there's different ways that this could look like versus, having it be all on the carrier side or all on the provider side. And they might have different implications for the cost in the system.
Anyone else? Shannon? If you're talking, you're still on mute, Shannon.
Oh, sorry.
That's okay.
I mentioned this the last time we had the meeting too about the concept of postgraduate training for nurse practitioners and PAs. And there are now 600 such programs in the country, and they're showing a great improvement in retention and competency and productivity in primary care settings. The Millback quarterly report that one of you mentioned cites this as an option to help develop workforce because we have a high turnover when new grads come into rural areas. We do very well when we do 1 year of postgraduate training. Right now, 0.1% of federal dollars is going toward this action. We're working on other ways, but I just wanted to say that we can improve the productivity and satisfaction and retention in primary care settings by working on ways to do the programs like we did funded by Primera for 5 years in 20 rural sites in Washington State. I'm happy to send more information about this, but I want to remember that we can really improve the productivity and quality of care by doing this.
Great. I think that is, I'm going to shift it because I think that's actually a great workforce development recommendation we can make. So.
Oh, yes, that's what I meant to say when I was on mute.
Oh, excellent. Well, then, yes, hold that thought. But we are going to focus on finalizing the primary care ratio first, and then we'll do like each one. So, yes, I think that's a great one. And I like it a lot. Elizabeth?
I just want to convey my support for this. I think we have been dealing with a goal for quite some time, but this seems like it's turning it into an actionable pathway. And I think some of the other states that we've heard from that do have primary care spend increase do it as a result of having it be mandated from the legislature. So I think this is really important.
Great. Yes. Is there more discussion? Or does someone want to make a motion? And I think the key parts are that we've added to this is to reach and maintain, to potentially consider options that might be different for carriers and providers. And then I also figuring out where to put our support for the universal primary care bill that OIC is doing. And I agree this might be a place, I think we could either put it here or it can be its own recommendation. So I don't know. What do folks want to do?
Judy, real quick, before you guys
Yeah.
vote, I'm just wondering, since there have been several proposed changes, if it would make sense maybe having the committee members email in their proposed changes just to make sure we're capturing the language correctly. And then for this first one, maybe we take the vote that way. I want to make sure I'm capturing everything and that the suggestions are incorporated into this vote language before it goes to the cost board.
An alternative as well, sorry, Ross Glory, could be that we could send out updated recommendations after the meeting so that members could see what they look like with the updated language, and then we could get approval that way. There's some conditions that would have to be put on that. We can't communicate with the full body via email, but so just a couple options if folks aren't comfortable approving these just on the verbal modifications.
I will say that I was not suggesting that what I said was the final thing, but I was suggesting a committee member might say their whole recommendation and then see where if folks have modifications or changes on that, because I think we could talk it out too. So all of those are options. And Elizabeth, is your hand raised again?
No.
Okay. Yeah. How do you guys want to go about this? No motions?
I guess, Judy, can you clarify what the ask is right now?
Yeah, so we need a motion and a vote on recommendations to the cost board. And so I'd say there are three ways to do that. One is to verbally change what is on the screen to make a motion. One is to email Rochelle your ideas for a motion so that we have that in writing, and I don't know if we could share it then. And then third is that we could take this discussion plus minus your written recommendations and come up with new wording that you could vote on by email. The downside to that is we will not be able to discuss it with each other or change it. It can only be a yes/no vote at that point.
Got it. Thank you for that overview.
Yes.
I'm happy to make a motion, if welcome.
Excellent. Yes.
Like to make a verbal motion regarding the primary care ratio, to have it be carriers and large provider organizations increase primary care spending, increase and maintain. Apologies. Maintain should be later on. Starting over. Carriers and large provider organizations increase primary care spending by 1% annually to reach and maintain 12% goal. Separately, I think some sort of recommendation in support of the common fund I want to be in favor of pursuing, but I feel like that should be a separate one.
Okay, great. Does anyone second that motion or is there further discussion? Thanks, Katina. All in favor say aye.
Email.
Aye.
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 And once you sent the one email,
And anyone opposed? Excellent. That first recommendation passes. We will make sure that some of the color around thinking about options also gets passed. It'll probably end up in the writing part of the report, but yeah, I think that's great. Does someone want to make a motion about the universal primary care topic? I don't know, just because we've talked about it, it can fit under this or it can be its own standalone, I think. We don't have to necessarily stick with these overall things, but we were trying to sort of summarize the areas that we've talked about. But I think this universal primary care is slightly separate, although we have talked with people about it. So yes. Katina?
Judy, I think it's a great idea, and I move that we support the universal primary care that was just kind of discussed earlier in the meeting. Yeah, the concept of that coming out of the OIC office. Is that what you want?
That is what I want. Any discussion about that motion? Or does anyone want to second it? Jonathan?
A comment in a second. The comment is, I believe that legislation is not for the immediate creation of a common fund, but almost to create a committee similar to this one to hammer out what the details would be. And so what I would like to offer support for seconding is the more explicit exploration on the mechanics of creating a common fund, so that it's thoughtfully created. Which is what I believe the OIC legislation is.
Yes. So, or Nico?
Hi, Judy. I don't think I have any official seat on this advisory committee, but I just wanted to confirm the previous comment in the OIC request legislation to examine the mechanics of common fund as part of the design that we're pursuing. So I don't mean to do any kind of action that we defer to this group to do that, but just to confirm that point that was raised.
Great, thank you. So any modified motion? Or do we have it and seconded?
I'll second the motion to support the OIC primary care carve out.
Okay. Maybe support the bill idea or something like that.
Yeah, like the concept of the bill or something, but definitely in support of exploring further. It's very creative idea.
Yes, I agree. Super creative and yeah.
Seems like it needs to be like a separate, its own recommendation, I think. Don't you think?
And its own recommendation?
Yeah.
Yeah.
Yes, kind of what
I think so. Okay, folks in the room, do you think you have enough there?
We're trying to type up what you guys are saying. That way we can screen share and show you real time. And then you can let us know if there's any additional revisions that need to happen. So if you guys want to keep talking, and then I will screen share as soon as we're able.
I think we might be ready for a vote on this one.
So that's an additional one you're saying?
An additional one that doesn't fall into these categories, but is its own standalone recommendation.
Okay. Do you want to move on to the next one in the meantime while we're typing this up real quick?
Sure. And then we can go back to that vote because yes.
Yes.
It is, this is stretching the limits of our fancy electronic sharing. So the second area that we've talked about is the healthcare transaction oversight. The cost board has already moved this recommendation forward to be a recommendation to the legislature. So our action would be on here to endorse that recommendation that the state pursue a healthcare transaction review program. Because we are the primary care committee, if someone wanted to add some specific language about primary care in that transaction review, you could do that. Otherwise, do people have questions, discussion about this one?
Judy, I think we might have language in here. I'm going to move forward just real quick. I could come back, but I feel like it might be in here.
Okay.
Okay. This is recommendation 2.
And so this is the recommendation that the cost board passed?
No. The cost board voted to recommend that the legislature pursue a transaction review program and committed to providing a more refined, specific transaction review proposal in 2027. I believe what you're seeing on the screen right now is a proposed recommendation from the Primary Care Committee related to transaction review to mitigate impacts of consolidation.
Okay, so this would be potential words for people to use, but they could be changed if someone is so inclined.
Right.
Okay. Excellent. It's helpful to have more words on the screen. Discussion about this?
I like this one a lot. I would move to approve. I also have to step away for a moment, so I just wanted to make that known in case there's broader discussion. Some language that I would like to add it to the last line for does not erode affordability, access, and then add maybe or viability of independent primary care practice. Thank you.
Okay.
Thank you, Jonathan.
Is there more discussion, or does anyone want to second that with the added words there?
Yeah, the added words he said was at the end was for viability of independent primary care practice.
Second.
Sorry, can you say who seconded that? I missed it.
Katina.
Katina.
Okay, thank you.
All in favor?
The middle of shutting down their organization.
Aye.
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 Any opposed? Okay, that passes. Thank you.
Okay, perfect. And then this is the third one, the invest in primary care workforce recommendation.
Okay, so there are 3 pieces here for you to consider that you can delete, change, or add to, and we've had one addition already. So one is to explore creating a compressed medical school plus primary care residency that would be a faster track to completing the medical education. 2 is ensuring that international medical graduates can continue to match in Washington residency programs because they tend to be more likely to match, especially in family medicine, and they're more likely to practice in more rural areas. And then 3rd is develop incentives to maintain or grow family medicine training. I think all of you know there were a couple of hospitals that decided to stop supporting family medicine residency slots. And so, so something might need to change there. Then I'd like to add potentially 2 or 3 things to that. One is, and I think it was Shannon, and I don't know the words that you want to use, but I think consider implementing a 1-year postgraduate education for APRNs. Did I say that right?
This is Shannon. First of all, these already exist. So what I would recommend that we say is
So it's planning.
explore continuing or for supporting financially the postgraduate training programs for nurse practitioners and physician assistants, especially with a focus in primary care. We already have 30 of these in Washington State, and the employers are all funding them. So there's CMAR, ICHS, Yakima Valley Farmers Work, and they're hiring new grads into these residencies and then keeping them on with success. So if there's a way to say, explore or continue support for postgraduate training for nurse practitioners and physician assistants in primary care. Because some of these exist in specialty care and we want to focus on primary care.
That sounds great. Yes, thank you for that.
Judy, sorry, I was having a hard time hearing her. I think because the air conditioning's on and she's talking a little bit quieter. Could you summarize what Shannon just said to make sure that we're capturing it correctly on our document?
Yeah. So check me if I got this right, but support postgraduate education for nurse practitioners and physician assistants in primary care.
The only adaptation I might make would be to consider providing financial support to the existing programs in Washington State. We already have
Okay.
25. We already have 25 of these programs. And they received essentially no federal or state funding, and so it's employers funding them. So I'm going to say existing or new, but the existing ones have a record of success already. So I don't know. I'm speaking loudly enough. I'm kind of in a noisy space. So
I can hear you better now, Shannon.
okay. Yeah,
I'm
so
just-
the idea is there is solid data emerging everywhere that when you support new graduates out of family nurse practitioner programs in structured, rigorous postgraduate training programs, you keep them, they stay, they bill, it's good. So how could we say that? And I guess I'm proud of the ones we already have that are making it despite any help. So existing and new.
If you could clarify, it was the financial support part. I feel like
Yes,
that
yes.
was the part I
Yes.
just need clarification.
I think I think I would say, fine, okay. Just explore funding for existing primary care postgraduate training programs for nurse practitioners and physician assistants. All of them include nurse practitioners and PAs, and whenever possible, I like to be with both.
That sounds great. And then Elizabeth, you emailed, I think you have a couple of options to add to this too.
Yeah, thank you. I think this is a really nice segue to say that overall, the future of primary care, I think, is in healthcare teams that involve nurse practitioners and PAs, and also primary care physicians. And I am actually reluctant to support the compressed medical school and primary care residency. I think that instead, I would support training, postgraduate training for nurse practitioners and PAs in the way that Shannon described, and additionally protect and grow family medicine training pipeline, funding existing family medicine residency positions, and adding incentives for programs to expand, particularly in communities where there's workforce shortages. I think that the problem of recruitment is not one of the training is too long. It's more a problem of the seeing value in family medicine or in internal medicine, primary care, pediatrics, primary care. So that is my second proposal, is increase the value proposition by investing more in mentorship, faculty, research, leadership opportunities, so that students see this as a viable career to enter. So yes, I did send a couple of worded proposals, and really it's to replace just the first bullet point.
Okay, that's great. And yes, I am not tied to any of the bullet points we started with, so we can cross off that one about the compressed timeline. I like, yeah, I like some of the discussion we've had about how to do this. So yes. Oh, excellent. And we have some words on the screen to edit in real time. Thank you so much, Ross and Rochelle.
That was all Ross. I was trying to take notes, but I'm like, I can't type this up fast enough to make sure everything's there. So he was able to do this. Okay, so which one are you guys currently voting on? The fourth one, workforce?
So number 1 on workforce, we're going to delete, I think.
The compressed medical school.
And then the one that's under 2 little I that's labeled number 1, we're going to pull that out to be its own recommendation.
I'm trying to put a strike through it so I know you guys wanted this gone. Okay.
Yes.
And then, sorry, what was the next one?
Number 1 is actually a little I recommendation. It's not part of the international medical graduates.
This one I have highlighted.
Yeah.
Wait, sorry, where am I supposed to move this one?
Just take away the indentation. It's its own recommendation.
Oh, gotcha. Okay.
I know we're watching you edit things, which I recognize can be a stressful thing to do.
No, I feel like I'm like hitting the wrong buttons because
yes, no worries.
off to the side. Okay. So turn this one into a separate recommendation. Are you saying like instead of workforce, have this as?
No, it's under workforce. It's just another recommendation under workforce.
Okay.
So if you like delete it back up to that last line and then push return, it'll renumber it, I think. There we go.
My goodness. Okay.
And then if you can get into your email, Elizabeth wrote down a couple of recommendations that you could copy and paste into there.
Okay. I'm going to stop sharing real quick so I can grab it.
Okay. This is why we had extra time, because I knew we'd have a lot of discussion about some of these, and I'm excited to have some fresh ideas here. And so, yes.
Oh, gotcha. Okay. Okay, that's right. Yeah.
Sorry, all. Thank you for your patience as we.
Yes, format this real quick and then re-screen share. Okay,
it's
I
totally
added
fine.
Elizabeth's in here, where it says 5612. It formatted it a little weird, but I wanted to, draw attention to what the new additions were. So
great. And they all fit under things. So we have 5 workforce recommendations right now. Jonathan?
Really like the new additions, and so I think they largely address what my concern was. But looking at 5.1, for IV develop incentives to maintain / grow family medicine training. I feel like the word incentives just sort of denotes sort of positive encouragements to create. I am concerned about, recent actions in the state of multiple family medicine residency training closures. And I know that the legislature is not Medicare, where probably the main levers are, but I do wonder if there's a place for us to encourage like enforcement mechanisms to discourage closures of family medicine residency programs. And so if like IV could be like Roman numeral 4 could be like develop incentives to grow and enforcement mechanisms to maintain family medicine training.
I think we could delete number 4 and add that to the 5.1.1. Because I agree, I think there probably needs to be legislative action there. I will also say that there are Medicaid funds to support GME that are currently built into hospital payments, so everybody gets a little bit of that. There could be some recommendations around that. Katina, you were shaking your head vigorously to that.
Yes, I knew you knew that there was GME patients from Medicaid through your office, but how could we strengthen that? I don't have a particular recommendation, but more Medicaid spending to programs, I think could benefit programs, and more transparency around how the Medicaid money actually flows to programs, because it often goes into the ether of the hospital system and not to the programs themselves. As a former residency director, I don't have language for that.
Yeah, I agree. I think either transparency or potentially carving out of hospital reimbursement the current Medicaid GME funding that exists could be something the legislature could ask HCA to do. And that would hopefully, in my own opinion, be an incentive for hospitals to know that that is there and yeah, do something. So, Lon?
Hello, I'm in support of the recommendation 3 for workforce development, and I think our language has been investing in primary care workforce, and of course in support of growing family medicine. But I think family medicine training should probably be more broad to say primary care. So I think there were a couple of bullets where we say, and they're above this bullet too, where we just called out family medicine and just primary care broadly, because that's used in other bullets as well. And then the number 2, the small 2 I's there under A, I would probably make that more specific. Ensure IMGs can continue to match in Washington primary care residency programs.
Great, that's a nice addition. Elizabeth?
I just want to elucidate why I said primary care I said family medicine rather than primary care. I think one of the problems is that residencies in internal medicine and pediatrics are largely embedded in hospital, academic hospital settings, whereas family medicine residencies tend to be, not always, but in more community sites. And so that's kind of why I was separating out family medicine in that particular instance.
I would agree with keeping it in family medicine. I think also in our state, a lot of the internal medicine and pediatric residents go on to subspecialize. There are several that are primary care focused. I am programs or pediatric programs, but many of those residents do subspecialize, and we kind of lose them from primary care. And there's already an infrastructure within the family medicine residency network to help support the good things that go on there. So I would second the concept of leaving it at family medicine residencies.
Maybe we could change 4 to be protect and grow the primary care training pipeline with a focus on family medicine, because I do think we need all the kinds of providers, and family medicine is, I think, low-hanging fruit to focus on for some of this. I think especially the closure of those 2 programs, I think, was a really big hit to primary care in general in Washington State. Is that a good friendly amendment?
Sorry, so Judy, for 4, you said protect and grow the primary care training pipeline, and you want me to put with emphasis on family medicine?
Yes.
Is that your, okay.
Or maybe you could just say community-based programs, then we don't have to
Oh, I like that. Yeah.
say call family medicine out preferentially.
Okay.
I do think under there, though, the provide stable and ongoing state funding for existing family medicine residency programs and additional incentives for programs to expand, I think could stay family medicine, but then maybe develop incentives to maintain and grow community-based primary care training programs.
This last line, so it would be
To
develop.
maintain and grow community-based primary care training programs.
Where do we add a bullet regarding the carving out the Medicaid money?
We could add that right here. Do you want to give some words to that?
Judy, you had good words.
I know, but I'm
should've
not
written it
sure,
down.
especially me being at HCA, should provide that recommendation.
Huh. Here, I will think of some words because I didn't write it down.
I think it would have more, yes. Coming from this committee and not from me, I think gives it more heft, so.
And if you want to email that in the same way that Elizabeth did, that does make it easier, and I can just copy and paste that to make sure I'm capturing it correctly.
In the meantime, any conversation about 5 here?
We could change this to primary care instead of family medicine, in my opinion.
Okay. Other comments, thoughts, edits? Maddie?
So just the one you were just editing, we still say family medicine down in the middle of it, the 3rd line down. So students experience family medicine as a rigorous, meaningful, change it to primary care, just to be consistent.
Sounds good. other comments on this one, or maybe we can scroll up and sort of review what we have here? So the recommendation 2, any further changes or comments or discussion on that? Maddie?
Just one more comment. Are we rank ordering these, or are we saying we want all of these to occur?
Right now it's saying that we want all of these to occur. If you want to rank order them, you can, but also I'd say that you don't have to. You can ask for all the cake. Jonathan?
A similar comment to Maddie's prior comment for terms for sub-bullet 4 in the body. It currently says family medicine in line 1 if you wanted to change that to primary care.
Great. Lon?
Can I motion to approve the recommendations here?
You can. Do we want to add one more about pulling out Medicaid GME? And then we can vote on all of the workforce recommendations. Katina, are you ready for that?
I'm trying to type away and send an email.
Okay, you can say it if you want.
To carve out the Medicaid GME funds to go to programs rather than institutions. Or when we said something about transparency. We have a hive. Jonathan, you're good at warning things.
Yes. Are you typing this, Rochelle, or waiting?
Yeah, I was waiting.
Okay, I think carve out, I'll rephrase this. So I think the 2 doesn't need to be there because it's a verb. So carve out the Medicaid GME funds from hospital rates to flow directly to programs or primary care residency programs in order to have transparency and provide an incentive. I don't know. Maybe I'm going too far now. So thanks. Oh, I like that. In order to provide an incentive and promote transparency, we can delete the words in between order and provide. Do people have other discussions or comments about this one?
Just a grammar thing. Line 2 before provide, I think in is supposed to be to, T-O.
Oh, yes, instead of in.
Yeah. To provide an incentive and promote transparency.
Good catch.
Anything else, or Lon, do you want to make a motion?
Yes, I motion to approve all language underneath the workforce development that we see here.
Great. Any seconds?
Katina, second.
Okay, all in favor, say aye.
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 Any opposed? Perfect. We have some workforce recommendations. Congratulations. And then I think we have one more up higher on this for the universal primary care. So support exploration of OIC's comprehensive primary care proposal to study mechanics of common fund and regular updates to the primary care advisory committee. Any discussion or wording of that? There might need to be some word changes there, I think.
Yeah. Maybe to study the mechanics of a common fund and to make regular updates to the primary care advisory committee.
I think a common fund.
Yeah.
A common fund.
Any further discussion, wording, modifications, Elizabeth?
This might be too much, but I had brainstormed this before this meeting, and so I did just send a couple of other things that I think represent different categories, which may not be appropriate for this meeting, but I sent them via email that don't have to fall within these categories, but I don't know if there's time for discussion or not.
I don't see them in my email. Do you want to, well, let's vote on the OIC one first. Does anyone have a motion for that? Maddie?
One more question first. Do we know what we mean by common fund in the wording of the OIC?
I think I do, but I am open to other words.
I don't know, or is it, I mean, if everyone knows it and understands it in this whole political workforce here we're doing, then it's okay, but I didn't know how that goes across. Or do we need to capitalize it or put it in quotes or something? Because we don't really have a common fund, do we?
We don't. The proposal is
Okay.
to explore creating a common
Getting
fund
one.
for
Okay.
primary care.
Yeah. So I think I would either capitalize it or put it in quotes or something. I don't know.
Okay.
And then I'm willing to make a motion to accept this
Okay.
OIC
Nico,
section.
do you have anything to add about this?
Yes, thank you again. I'm not a committee member, but just the question about what the OIC request legislation means with common fund. Yes, that is something that we would be developing in the work, and it's not defined in like bill text right now, but Judy's correct in terms of the concept, right? So I think you're right, Judy, just to confirm that.
And just to clarify, Nico, that's a financing mechanism that would help fund the primary care work that you're discussing.
Correct. In the outside of traditional insurance-based, the traditional insurance-based model that predominantly is used today. Correct.
Okay, great.
So Maddie had a motion to approve. Is there a second?
I added Elizabeth's updates on here. I'm not sure if Maddie made that motion before I added them, so I just wanted to draw it to everyone's attention.
Yes, these other ones take additional discussion. So I just want to vote on the OIC one first, and then we can talk about the other ones. So is there a second for the OIC comprehensive primary care proposal?
I second that.
Great, thanks, Elizabeth. All in favor, say aye.
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 And any
Aye.
opposed? Great, that one passes. And then Elizabeth gave 4 more recommendations. Do people want to review these, take any action now? Think about it for next year. We have a lot of options and 13 minutes. Plenty of time to keep fixing primary care.
And we were just pulling those out because I believe, correct me if I'm wrong, Elizabeth, those are standalone recommendations. They don't directly tie back to any of the previous recommendations we've noted.
There is one that overlaps with workforce, but
Okay.
yes, otherwise they are standalone.
Great. So if we can pull those up, and then Elizabeth, you can talk about them.
The administrative burden, I think, for anyone who's encountered practice is a major problem in the rates of burnout for primary care. So this is an attempt to standardize many of the administrative burden things that we are tasked to do, so that it's not a guessing game every single time. And then continuity of care, as many articles are sharing, is really the hallmark of primary care, the value of primary care, and yet we really don't do a great job measuring it or recognizing it or rewarding it. And so the second bullet point points to that. And then the third bullet point really points to keeping more care within primary care as opposed to spending money on more expensive specialty care. And so a statewide e-consultation, which allows primary care teams to be the hub of the care, and then just e-consult with specialists, I think would help reduce overall cost of care. And then the dashboard is really just a way to, or workforce dashboard is a way to say that as we increase clinicians and further understand where they practice and what their panel capacity, and just identify the factors of accessing primary care, then we can later discern whether or not that actually contributes to improved costs and outcomes down the road. Yeah.
Great. Does anyone want to discuss these, add them, change them?
I think they're excellent. And the administrative burden, for instance, somebody mentioned about how we heard that Kaiser has a higher percentage of care in primary care. One of the things they've done is to really work on reducing the administrative burden on their primary care clinicians by doing exactly what was talked about, the e-consulting and the ability to really focus with case management and having ancillary help with that for primary care providers. So I think these are great ideas. They're more operational instead of policy related, but I think they're all good.
Great. Katina?
I just wondered, I love these ideas. I think they're all really great ideas. And I remember last year when we were going through the list, we had decided we were going to really focus on a smaller number to hopefully have a bigger impact. And I wondered how the committee kind of thought about, we already just increased our recommendations with sub recommendations, if how we prioritize that.
Thoughts about that? Lon?
Thanks. Yeah, not specifically to answer Katina's question, but I really like the specialty access as a primary care issue and how do we help PCPs work to the top of their licensure. Maybe this is the one that falls under workforce that you were referring to, but really having that statewide PCP optimization, but certainly specialty access as e-consult. I really like that idea. And I do think that does help with our workforce sustainability and joint practice.
It was the workforce dashboard that I thought went better under workforce, but I think they both could tie in.
And Judy, since we're almost out of time, I just want to make sure that we have voted on the first one. I think that was the other one that we had to circle back to, the very first recommendation.
We did vote on that one. We started with that one voting.
This one, okay.
Yeah.
And as we noted earlier in the meeting, we will, I think it'd be appropriate for us to add this document to the amended meeting packet post-meeting. So folks that weren't able to attend can see the progress that was made here. So we'll also do that as well.
Okay, so I moved two of those workforce recommendations under the workforce category, Elizabeth's additions, and then for the remaining ones, was there anything?
Yeah, do people want to add those two to the workforce? Maybe we'll start there. Do we want to do that later? I agree. The cost board in the past has limited sometimes the number of things that they moved forward, and that doesn't mean we shouldn't do that. I
think a recommendation is to prioritize, especially the ones under workforce. We have a lot now, so maybe we pick our top 2 or 3.
We could do that. Does anyone have ideas about how to do that in 6 minutes or less? Elizabeth?
I mean, does it make sense to offer to the cost board, these are our recommendations, but we acknowledge that within the cost board's priorities, they may whittle down some of these recommendations, because I can imagine some of these are going to be resonant with what they're already doing, and some of them are going to be pretty separate. So I don't know if that's how it works, but maybe that's a tactic. I think there is a lot of interest in primary care innovation and development from the cost board, at least the meetings that I've attended. And so maybe more is better this time around. I don't know.
Okay, Jonathan?
Maybe one tack, we could have like 2 sections, one being the initial 4 that we discussed, have that heading being like advisory committee prioritized recommendations, and then the additional recommendations could maybe be called additional recommendations, just to capture people's eye around whichever ones we want to put our nickel down on without losing these great insights.
We could also figure out a way to have people sort of vote and put priorities in place, I think, that wouldn't allow for discussion. So whatever the results are the results, but we could do that if people were interested, I think.
And just to speak to kind of where this is going, at least what we did last year. In our cost board legislative report, which we submit to the legislature in November, we did include the Primary Care Advisory Committee's recommendations in full. But as Dr. Judy noted, at the cost board level, they did not take all of those individually, but just signaling in terms of our legislative report, these could be reproduced in full, but that they may not, the cost board may not endorse all of those individually. So there will be some awareness of these and included in the legislative report, if that helps at all.
Great. So maybe where we are, we have 3 minutes left. Do we have a motion, Crystal? Or another comment if you want that?
Sorry, quick comment. I just wonder if there's the ability to get it out via email and for us to start prioritizing, and then we just huddle back even for another hour meeting, or is that not really allowable? We don't have time for that.
We can, oh, so go ahead.
Go ahead, Russ.
We can hold special meetings. There are some notice requirements and obviously require coordination. So that is a possibility, but given where we are in August, I do think that may be a challenge to find time on everyone's calendar before the cost board gets to approving recommendations. So it would have to be within the next month, which I think would be difficult. But it is a possibility, but I do think it would be difficult.
Do people want to try and do that? I think say aye if you do, or we can see if there's something we can do virtually, or just put all these in, and this shows that we are all very passionate about primary care.
I like putting all of them in, and I was encouraged by your comment earlier that nobody asked you to put them in list or priority. Just everything. We need it all.
Okay. Then we need to vote on these last 4 before they can be included. Does anyone have a motion?
So moved.
So to include these 2 new categories under workforce, and then these 2 new standalone recommendations.
Yes, I was thinking the standalone recommendations could be titled something like retention or
I think we don't have time to title them because we're at time. Maybe does someone have a second to Shannon's motion?
Yeah, Katina, second.
Okay, all in favor say aye.
Aye.
Aye. Anyone opposed? Okay. Thank you. Thank you, everyone. In the last minute, I want to say that I appreciate all of you and the work that you've done over this last year. It takes a lot of time and thought, and I am excited about our recommendations that will input directly to the cost board. And so that brings us to the end of this meeting. So our recommendations are going to be shared at the cost board at our next meeting, September 23rd. I encourage you to come if you are interested. And then we don't have our next meeting date set, but it'll be in 2027. And then we'll reach out with the 2027 calendar. It'll be similar to this year in that we'll pick some areas of focus and discussion, and then share the primary care spend information and make recommendations for next year. If you have topics that you'd like to dive deep into next year, please let me know. And if we are going to look at we've had some people drop off this committee, so if there are gaps that you see that we need additional folks on, also please let me know. And with that, the meeting is ended at 4:31. Thank you all for your time and engagement today.
Thanks, Judy.
Thanks.
Thanks, Judy.